So first, I want to say welcome to everyone interviewing here at Idaho State University. My name is Leticia Herrera. I'm a second-year graduate student in the PhD Experimental Lab. I work with Dr. Michelle Brumley. The project I will be talking about is on development and recovery of motor behavior in neonatal spinal transected rats, where we look at changes in hind limb weight-bearing locomotion. There are approximately 250,000 to 500,000 spinal cord injury cases globally each year. These cases vary in severity, where some can cause permanent damage to the spinal cord, which leads to loss of motor functions. However, through research, we know that there's an increase in recovery of motor functions if the spinal cord injury occurs during early development compared to if it occurred during adulthood. We also know that the isolated spinal cord is able to adapt and function without regeneration across the lesion. Therefore, knowing that development and age is very important and crucial for recovery, we hypothesize that neonatal spinal transected rats will recover some weight-bearing locomotion by weaning age due to the plasticity of the developing spinal cord. Our project consisted of 40 Sprague Dawley rats. In these orange boxes, you can see our 4 different groups that differed by surgery, spinal transected and sham treated, and also varied by sex, male and female. So each rat on postnatal day 1 received either a low thoracic spinal cord transection or sham surgery. They received pain medication and daily health checks to assure a healthy recovery. On postnatal day 21, they were tested for 20 minutes in an open field. All sessions were recorded, and we later analyzed hind limb weight-bearing activity that was categorized into 3 groups: non, partial, and full. So for the non-weight-bearing group, it refers to when the rat has no support from its hind limbs. Here in this picture, you can see the rat is stationary. You can also see that its abdomen and hind leg quarters are on the plexiglass floor. So this is showing that there's no weight bearing on its hind limbs. All the data graphs will have the surgery group on the x-axis and the duration in seconds on the y-axis. When we analyzed non-weight bearing, we found a main effect of surgery where spinal subjects showed more non-weight bearing movement. For partial weight bearing, it refers to when the rat has some support from its hind limbs, but not fully. In the picture, you can see the rat does show some partial weight bearing because its hind limbs are being used as it's walking across the chamber, but its abdomen is still in contact with the floor. When we analyzed partial weight bearing, we found the main effect of surgery, where spinal subjects showed more partial weight bearing movement. Full weight bearing refers to when the rat has full support from its hind limbs. In this picture, you can see the rat is propelled forward as it's walking. Its posture is horizontal and its abdomen is off the floor. When we analyzed full weight bearing, we found a main effect of surgery where sham subjects showed more full weight bearing movement. Interestingly, when we decided to analyze all total movement of all 4 groups, we found no group differences. So this means that there was no difference in total movement for spinal and sham rats and no sex differences. This also shows us that each rat was able and capable of moving just as much as each other. This is important because it tells us that the quality, not the quantity of movement is being affected in rats at the age of P21 after a spinal cord injury. When looking at the data, we also saw a few spinal transected rats that showed full weight bearing movement, although it was only for brief duration. This is important because it supports the idea that spinal cord can support substantial hind limb locomotion, even when isolated from brain inputs. As we've seen, this data shows comparable levels of hind limb activity between neonatal spinal transected and sham rats at the age of P21. So this is different from other research that had rats at the age of P10, where spinal transected rats showed significantly less activity than shams. So as a whole, the Brumley lab is currently analyzing different ages at P7, P14, P21, and P50. We are interested in continuing to see plasticity and development and see if we have this same pattern of increased locomotion as the rat gets older. I want to say thank you to Dr. Brumley, the other graduate students in the lab, Amy and Elena, and all the Brumley lab researchers, and of course, most importantly, our rats. And my references.
My name is Gabby Perez. I'm a 3rd year in the clinical program. I work in Dr. Shannon Lynch's lab, And today I'll be presenting on a piece of a study that our lab has conducted that specifically explored interpersonal trauma, PTSD, and dissociation in incarcerated women. So first, some background. The number of incarcerated women has increased 11% in the past decade, despite the fact that the overall incarceration rate in the US has been decreasing in the past decade. The most recent national data we have estimates that women comprise anywhere from 12 to 16% of the adult jail population in the US. Historically, most research with incarcerated populations has focused on men, given that they're incarcerated at higher rates. However, the literature does suggest that women have distinct pathways to and risk factors for incarceration beyond the patterns that we tend to see with incarcerated men. So when we talk about interpersonal trauma, this encompasses events where an individual is personally assaulted or violated by another person, so including physical assault, being mugged or attacked, partner violence, and sexual assault, in addition to witnessing these events happening to another person. Incarcerated women exhibit incredibly high rates of trauma exposure compared to the general population, with some studies reporting as high as 92% of their samples experiencing interpersonal trauma at some point in their lifetimes. Therefore, not surprisingly, this population also has higher rates of post-traumatic stress disorder, or PTSD, than the general population, with around half of incarcerated women meeting criteria for lifetime PTSD, which includes symptoms like traumatic flashbacks, nightmares, and hypervigilance. And sometimes along with PTSD comes dissociation. So dissociation is an altered state of consciousness involving a decreased awareness of the environment. So that includes things like out-of-body experiences, detachment from one's identity, or a loss of connection with reality. And dissociation is quite common after interpersonal trauma, especially in individuals that have experienced child abuse. And therefore, research has found that anywhere from 6 to 30% of individuals with PTSD have dissociative symptoms. And while we have several evidence-based treatments for PTSD, it's unclear how much dissociation affects that treatment. So some studies have shown that individuals with high levels of dissociation may have difficulty engaging in treatment, but other studies have shown that some therapies do result in clinically significant decreases in dissociative symptoms. So onto the methods for this study. The sample consisted of 146 women from 2 jails here in Southeast Idaho, and women were randomly selected to participate. Women who participated completed interviews, which included the life stressors checklist, which assessed lifetime exposure to traumatic events, the PTSD checklist for DSM-5, and the dissociative experiences scale. So you had a diverse sample in terms of race and ethnicity. It was select all that apply, so the percentages won't add up to 100, but most women identified as white or European American, followed by 15% that identified as American Indian or Native American, followed by Hispanic, European, African American or Black, and Asian American women. The sample also had a wide range of incomes and education levels. Annual income ranged from $0 to $60,000, with a mean of about $2,700 per year. Education ranged from less than 6th grade to a graduate degree, with a large portion of the sample either obtaining their GED or attending some college. So within our sample, 99.3% of women reported at least one experience in their lifetime of interpersonal violence. So that is 145 out of the total sample of 146 women. 86.3% reported lifetime experiences of physical violence, so that included childhood or adulthood physical assault. And then 85.6% reported lifetime experiences of sexual violence, so that is any form of non-consensual sexual touch. And so there's also a lot of overlap, as the majority of women did report experiencing both physical and sexual violence in their lifetimes. In terms of mental health outcomes, previous experiences of interpersonal trauma were significantly associated with PTSD and dissociation at the time of interview, which was expected. 60% of women scored in the probable PTSD range on the PCL-5, and 22% of women reported clinical levels of dissociation on the DES. So these results support the existing literature indicating that incarcerated women present with high rates of interpersonal violence exposure compared to women in the general population, in addition to high rates of trauma-related distress in the forms of PTSD and dissociation. These results also highlight the need for early intervention after traumatic experiences and screening for common trauma-related disorders like PTSD, in addition to the need for treatment in corrections facilities in particular. So that leads us to some treatment implications. This is a unique time to intervene and provide resources to women that may not otherwise have access to them. But however, this population does have additional considerations that are relevant for treatment. So first, we often see other comorbid mental health conditions and substance use problems, which have to be considered when you're doing treatment. Second, we have to consider the limitations of the facility. So for example, the amount of free time the women get and when. So you don't want to be running treatment during their phone time or when a new episode of a good TV show is on. We also have to make appropriate adaptations or additions to protocols to fit the needs of this population. So, for example, you have to take into account the wide range of reading levels in the population, as that can impact your handouts or your resources. Another major one is promoting empowerment and autonomy in different ways. So, for example, if we're doing group therapy, getting input from the participants on the group rules and expectations, or even just allowing the participants to choose where to sit, right? I mean, it seems very minimal, but that choice is vastly different than most other contexts that they're experiencing while incarcerated. So there are just some small adjustments or additions to a treatment protocol that can really make a difference in treatment with this population. So I know that's heavy, but I think it's important. So I appreciate y'all hanging in there. And I think now I'm going to pass it on to Sam.
Hi, everyone. Welcome to Interview Weekend. My name is Sam Johnston. I'm a third year graduate student in the clinical program, and I work with Dr. Robert Risky. Today, I'm going to be presenting my thesis titled Parent Involvement in Autism Spectrum Disorder Interventions, the Effects of Parent Internalizing Disorders and Self-Care Behaviors. So before I get started, also, I just want to make sure that my slide progressed. Okay, cool. So before I get started, I just want to give a brief overview of what I'll be discussing today. So first, I'll go over some literature review of the variables that I included within this study. Then I'll present my current study, and I'll go further into some hypotheses. Then I'll discuss my methods, and I'll finish my presentation with a discussion of the results that we found. So starting with my literature review, sorry, oh my goodness. Okay, starting with my literature review, autism spectrum disorder is a neurodevelopmental disability that's characterized by differences in communication and social interaction, as well as repetitive and stereotyped behaviors and interest. It's important to recognize that ASD is a lifelong disability. In some form or fashion, this will progress through the lifespan of an individual. The next variable that I included within my study is internalizing disorders. For this specific study, we were looking at just depression and anxiety, and for good reason. Cheneville and colleagues in 2020 found that anxiety and depression were the most common psychopathological disorders among parents of children diagnosed with ASD, with prevalence rates of 31% and 33% respectively, with the estimated global prevalence rate of depression at 4.4% and anxiety at 3.6% of the general population. So we can see that the population that we chose for the study has really heightened experiences with these internalizing disorders. These internalizing disorders have been found to lead to poor parental functioning, strained interaction with their children, and disengaged parenting behavior. The next variable that we included within the study was self-care. So for this study, we decided to define self-care as purposeful engagement in behaviors that promote health and enhance well-being. And research regarding self-care within this population is very limited. So we had to look at other populations to really get a sense of what these behaviors look like. The last variable that we included within the study was parent involvement. So parents can be involved in their child's ASD interventions in various ways, including parent education, parent training, parents as collaborators, etc. And when parents are involved in their child's treatment, it has been known to enhance the generalizability of the effects of the child's intervention. So the child is able to maintain those kinds of skills that they've learned in other settings. However, parents often find it difficult to engage in these kinds of interventions due to other commitments or stress that they may be experiencing. So now we'll discuss my current study. So within the study, we included 4 hypotheses. The first 3 are presented on this first slide. So the first hypothesis was that the presence of internalizing disorders will predict parent involvement such that parents of children diagnosed with ASD who present with internalizing disorders will exhibit less involvement in their child's treatment than those without an internalizing disorder. Our second hypothesis was that the intensity of internalizing disorders will predict parent involvement in their child's treatment such that parents of children diagnosed with ASD who experience a higher intensity of internalizing disorders will exhibit less involvement in their child's treatment. And then our third hypothesis was that the interference of internalizing disorders will be predictive of parent involvement in ASD interventions, such that parents who experience greater interference of internalizing disorders in their lives will be less involved than parents who experience less interference from internalizing disorders. And finally, my fourth hypothesis was that the engagement in self-care behaviors will be predictive of parental involvement, such that parents of children with ASD who engage in higher levels of self-care will exhibit more involvement in their child's intervention after accounting for the effects of internalizing disorders and any other potential covariates. Moving on to the methods, the study was an online data collection. And through that, we collected 84 participants. Participants were included within the study if they were parents of children with autism spectrum disorder between the ages of 2 to 10, if their child was currently receiving services, and if they understood and were able to read the English language. The measures that we included within the study involved the Parent Involvement Survey for Autism Treatment version 2, or the PISAT-2, the Patient Health Questionnaire 9, or the PHQ-9, the Generalized Anxiety Disorder 7, or the GAD-7, the Mindfulness Self-Care Scale, or the MSCS, and finally, the Autism Spectrum Rating Scale, or the ASRS. Some different demographics that we collected with this study. So parents who completed the survey, their mean age was about 34.8 with a standard deviation of 4.7. We collected data from 12 males and 71 females, as well as 1 non-binary or gender fluid individual. And parents reported a mean child age of about 5.5 with a standard deviation of 2.3. And they reported their child being male, 63 were male, and 21 were female. Now I'll get into my discussion of the results that we found. So for my primary hypotheses, those 4 that I initially showed you, the first 3 hypotheses were not significant. And this suggests that internalizing disorders do not have a relationship with parent involvement in autism spectrum treatment, as they do not show to influence parent involvement in that way. However, with our 4th hypothesis, we found that parents who engage in more self-care are more involved in their child's ASD intervention. It's important to recognize that while this population reports high levels of these internalizing disorders, it does not influence how they are involved in their child's intervention, but self-care significantly predicted that parent involvement. And finally, we found some interesting post hoc analyses. So when children were identified as white, parents reported higher rates of depression interference. When parents identified themselves as white, they reported higher rates of internalizing interference overall. When higher rates of ASD symptom severity was endorsed on the ASRS, parents reported higher rates of internalizing interference. And lastly, the strongest correlation was found between the interference of anxiety and the severity of autism symptoms. So with that, here are my references.
So my name is Morgan Musquez.
My name is Alam Alvarado.
And today we're representing Dr. Aaron Rasmussen's Health Decisions Lab. The project that we'll be presenting is titled Effects of Conditioned Food Cues on Delay Discounting in Binge Eating Prone and Binge Eating Resistant Rats. So food cues are images, odors, and advertisements that have been associated with food. And through classical conditioning, these food cues actually come to elicit similar food-related responses as food itself, such as salivation. It's been well documented from both human and non-human animal literature that the presence of food cues increases food consumption. And one group that is highly sensitive or reactive to these food cues are those with binge eating disorder. So in humans, binge eating disorder is characterized by repetitive episodes of consuming large quantities of food in the absence of compensatory behaviors, such as excessive exercise, the use of laxatives, or vomiting. And one way to experimentally identify factors that are related to binge eating in humans is through non-human animal models of binge eating. And one such group is the binge eating prone and binge eating resistant rat. So binge eating prone rats consume larger quantities of highly palatable food, so food that's high in sugar and fat content, when that food is available for short intermittent periods of time compared to binge eating resistant rats. Interestingly, though, both binge eating prone and binge eating resistant rats consume similar amounts of less palatable food. So that's food low in sugar and fat content, such as standard rat chow. Delayed discounting refers to preferences for smaller, sooner rewards over larger, delayed rewards. And in rats, we can determine discounting values by presenting them with smaller, sooner food options. So for example, one food pellet delivered immediately versus larger, later food options. So for example, 3 food pellets delivered after a delay. Historically, choices for the smaller, sooner reward have been described as more impulsive, whereas choices for the larger, later reward have been described as more self-controlled. So delayed discounting is associated with binge eating disorder, such that those who display binge eating behaviors tend to show preferences for the smaller, sooner food rewards over the larger, later food rewards. So this brings us to our current study. The purpose of the present study was to examine the extent to which conditioned food cues induce delayed discounting for food in binge eating prone and binge eating resistant rats. We hypothesized that food cues associated with highly palatable food would result in greater delayed discounting compared to a no cue baseline condition. Additionally, we also hypothesized that binge eating prone rats would exhibit higher rates of delayed discounting than binge eating resistant rats. So the subjects used in our study were 20 male Sprague Dolly rats. They first underwent a baseline delayed discounting procedure. So in this procedure, they were presented with choices of 1 food pellet delivered immediately, which was the smaller, sooner food reward, or 3 pellets delivered after a delay, which was the larger, later food reward. And here, higher discounting rates just meant that the rats preferred the smaller, sooner food reward over the larger, later food reward. To determine binge eating status, we exposed the rats to 4 4-hour sessions with ad libitum access to Oreo cookies, which is a highly palatable food. So the 10 rats that consistently ate the most Oreo cookie were classified as binge eating prone, and the 10 rats that consistently ate the least amount of Oreo cookie were classified as binge eating resistant. Rats then underwent food cue conditioning. So here we exposed the rats to 7 24-hour sessions in a distinct cookie cage, which was different than their home cage. So the cookie cage had black construction paper wrapped around the sides, and it was paired with Oreo cookie. So here the black construction paper served as the food cue. Rats then underwent a cued delay discounting procedure, which was identical to the baseline delay discounting procedure, except for now the food cue is present. So black construction paper was wrapped around the operant chamber.
Okay, so moving on to the results. This graph is going to show caloric consumption as a function of binge status. So on the left, we have binge eating resistant, and on the right, we have binge eating prone rats. The black bars represent the standard chow consumption, and the gray bars represent the Oreo cookie consumption. So to no surprise, we found that the binge eating prone rats consumed more calories than the binge eating resistant rats. This was because the binge eating prone rats consumed more calories from the Oreo cookies compared to the binge eating resistant rats. So if we look back at the graph, you can see that the binge eating prone rats consumed more Oreo cookies compared to the binge eating resistant rats. Next, binge eating prone and binge eating resistant rats also consumed similar amounts of standard chow. So once looking back at the graph, it's representative of the black bars. You can see that there's not many difference between the binge eating prone and binge eating resistant. So moving on, this graph is going to show the preference for larger later food reward as a function of Q type. So on the left, we have the no Q group, and on the right, we have the cookie Q group. The black bars represent the binge eating resistant rats, and the gray bars represent the binge eating prone rats. So what we found was that the cookie Q reduced preferences for the larger later food reward. Pairwise comparisons showed that this effect was primarily driven by the binge eating prone rats. So if we look back at the graph, you can see that the binge eating prone rats preferred the smaller sooner reward more in the cookie Q group compared to the binge eating prone rats in the no Q group. However, binge eating resistance rats showed no change between the two groups. Lastly, no differences in delayed discounting were observed between groups, and there was no Q by binge status interaction. So in conclusion, the binge eating status results replicate previous literature in which binge eating prone rats consume larger amounts of highly palatable food, but similar amounts of less palatable food relative to binge eating resistant rats. So our results suggest that the conditioned food cues induce delayed discounting. That is, they shift food preferences towards smaller, more immediate influences, but only for binge eating prone organisms. To our knowledge, it's the first reported food cue induced changes in delayed discounting for food in binge eating prone rats. So we hypothesized that no differences were observed in delayed discounting between binge eating prone and binge eating resistant rats because of the type of food pellet that was used. For example, in our study, we used grain-based pellets, which is a less palatable food. And another option would be to use sucrose-based pellets, which is a highly palatable food. So our lab plans to replicate the study using pellets that differ in palatability to compare Q delayed discounting between binge eating prone and binge eating resistant rats to more fully characterize the nuances of Q delayed discounting. Thank you.